Good afternoon, ladies and gentlemen. My name is Klekn. I'm the CEO of the National Expert and Training Center for Breast Cancer Screening in the Netherlands. And first of all, I want to thank the organization committee for inviting me to present the presentation Starting a Screening Program and Quality Control. I'm a colleague of the former speaker, Arten Hete, and he also told about the context of the screening. And the context of the screening and context of my presentation is that I'm also talking about screening, breast cancer screening, mammographic breast cancer screening, and the mammographic breast cancer service program, service screening. And service screening is an organized population-based screening program. Thank you. Okay. Before starting a screening program, it's very important that you know what kind of screening program do you want. Do you want an opportunistic, hospital-based and service screening, so an opportunistic, hospital-based or a service screening, and it's important that you know what kind of screenings test do you use. In my presentation, I will point out several points for setting up a business plan for a screening organization. And I will go into the quality assurance. Before you start a screening program, there are some points of attention to make, and some of those points are from the Wilson and Junger rules. First of all, screening is justified if there's an important health problem, and if an accepted treatment for recognized disease is available. So this is very important because you have to have an important health problem to go to screening, and there must be an accepted treatment for this disease. Also, for an organized screening program, you have to reach the entire target population for call and recall. So you have to have a system that you can identify the women you are going to invite to the screening program. And the compliance of more than 50% make a program effective. And we realize it's not easy to get a compliance of more than 50%, but you have to grow and you have to believe in it. And we think after several years you can reach that percentage. And this is very important. It's important that the government has a long-term vision and commitment to the screening program. They have to support the screening program because screening is not a program for 1, 2 or 3 years. It's a program for several years, 10, 20, 30 years at least. So there has to be a long-term vision and commitment. And radiographers and radiologists should be trained for screening. Screening is not the same as hospital care. So it's important that they have a separate training for screening. There must be a system of constant quality assurance. Because you screen healthy women, it's important that they can rely on you that the quality of your screening program is as high as possible. And there must be a monitoring system of the results so you can see if your program is working. And screening is not healthcare, so it should be strictly separated from healthcare. Healthy women go to screening, and women who are concerned that they have a disease or a complaint, they go to the hospital. Population-based screening program means according to the first report of cancer screening in the European Union, that each round of screening, the persons in the target population are individually identified and personally invited to attend the screening. So you know your women who you're going to invite, and you can identify them, so you can invite them each round. And generally, this requires a high degree of organization and population register. A population-based screening program is regional or national. An opportunistic screening is no organized screening program. We think that mammography is still the best evidence-based test for screening, and digital mammography is now standard of care. Before you thinking about setting up a screening program and make a business plan or something like that, it's important you know your epidemiology. Because it's important that you ask yourself what's the breast cancer mortality and incidence rate. And you need that to monitor the effectiveness of the program before the start. So before you start a screening program, it's important you know your mortality rate and your incidence rate. And you have to know what's the age variation in population. It's important to define the target population. And then you have to know how big is the target population and how big do you expect the participation rate will be. And this is very important to organize the program. If you, let's say, you have a target population of 100,000 women and you have a participation rate of 50% and you screen every 2 years, then you have 25,000 women who will be invited to come, who will be attending to the screening program. And then you know how much mobile units you need, how many radiographers you need, how many radiologists you need, how big your packs must be. So it's important to know your epidemiology so you can organize a good screening program. Well, this is from the cancer report in 2007 already mentioned. And then you see that breast cancer is the most common cancer in Saudi Arabia. So do you have an important health disease? Yes, you have. And 26% of the most common of the female population cancers is 26% is breast cancer. So you could say this is very important. You have your information, so you can start a screening program. Over here you see also from the report, it's difficult to read, this is the population, I think, 39 to 44 years. Breast cancer is the most common, and it's up to 75 years. Still the most common is breast cancer, and after that it's not the most common cancer. So this is important to decide what your age, your target population will be, and the age variation will be between 30 years and 75 years, and you have to decide to look into the numbers exactly to define the target population. Of course, when you set up a screening program, you need something like a project organization, project leader, a board, a foundation, people who are believing in the system, believing in screening, and they have a lot of energy and motivation to set up a good screening program. And you set your goals within how many years you want to set up and implement a good screening program, because it takes years. In Holland, in Netherlands, it took several years to roll out the whole screening program. And in that period, it's important that you have finance for the project, because otherwise the projects will stop because of lack of finance. And this is very important. The commitment of the stakeholders. And it means that, first of all, the government has to support a long-term screening program. That's important. And you have to have something like a public registry, or to invite women every 2 rounds to the screening program. And if you don't have a good public registry, perhaps you can use the information from the health insurance companies or other systems in your country who have a lot of information where women live and how you can reach them. But it's always difficult to get women to the screening program. They have to have a mindset that something new like screening in a country can save lives. Very important is the support of the hospital, because when a woman gets referred from screening to the hospital, it's important that within a few days women can attend to the hospital for treatment. In the Netherlands we have sometimes that women would have to wait for 6 weeks, and it's terrible. We get very angry when we hear that. And also we think it's very important to convince the family doctors or the GPs that screening is good for women, so that they can talk to women, they can advise women to participate in the screening program. Then you have the primary process. You have to decide, are you going to use double-blind reading? And how are you going to set up a screening unit? You have to make a choice for a mammographic system. There are a lot of good systems, but there are also very bad systems. And you have to make a choice for a workstation and a PACS. And it's important, and I saw in one of the slides of Dr. Meyer, that there's also that you describe your process. This is an example of a process, but this gives you the opportunity to organize each step and to describe each step. Okay, when a woman is invited, what's the first step? She will attend or she will not attend. Okay, what do we have to do if they're not attending? In the Netherlands, you get a new letter, a new invitation if you're not attending to screening. So it's an example where you can decide how you set up your screening program, how to describe it, and to organize each step. And also you have to make a choice, are we going to work with a fixed unit or a mobile unit, or both? Do we have the staff to examine the screening? Are they available, and do they have the right quality? Is there enough finance to do screening for more than 10, 20 years? And very important is the ICT. Do we have a good PACS? Do we have a good workstation? Do we have a digital workflow? Some examples. We helped to set up a screening program on the island of Curaçao. It's between North and South America, and it's a former Dutch island. And they chose to have a fixed unit, only a fixed unit, because it's a small island and all the women are able to come to the fixed unit. So this was the best solution. We also work with a hospital area in Brazil, and you can see these are different roads. They have to have a very good truck to go to all the small places in the middle of their region, and that's different from Holland, where we have good roads, we don't have any mountains, and we don't have a desert, and we have a lot of mobile trucks, and they are mostly about, I think, 1 or 2 months in one place. You don't see any truck, it's only the unit, and then once in every 2 months a driver will come with his truck and transport this mobile unit. And I was very happy that yesterday I saw your own mobile truck of Medina in the front of this hotel. So you have already made a decision to use mobile units next to a fixed unit. Most important is culture, but we think as a national expert and training center that the level of quality can be the same all over the world. The level of quality of equipment, the level of quality of radiographers, and the level of quality of radiologists can be the same all over the world. We can learn from each other and we can make this level as high as possible. But how to communicate with women and staff depends on the culture of your country. So you can't copy the Dutch way of screening to Saudi Arabia. It's very important you notice your own culture aspects. So we believe that trainers and teachers must be part of the culture of the country. And you have to use the teach the teacher of train the trainer situation. And we are very happy to help you with that. The communication and information is very important because it's all about the awareness of women. It's about early detection, and women have to know that. And it's very important how you invite women and how you tell them about the results. It's very important to give them the right information about screening. Not only the benefits, but also the harms, but in the right balance. And communication with family doctors, screening and hospital is very important, especially for the follow-up. So a hospital has to know, okay, we have a screening program, so that means that there will be some women referred to the hospital and we are ready to take care of them. Quality assurance. A breast cancer screening program demands the best possible quality of equipment and staff. That's our goal. We think this is important. If you have a screening program, if you screen healthy women, they have to rely on the best quality you can provide. So you could say there's some kind of chain of quality. The equipment is important and has to be perfect, but only if radiographers perform well, radiologists can perform well. So if there is an artifact in the equipment, the radiologist will refer because he sees an abnormality in the image. But if the positioning of the radiographer is wrong and there's a fault or the breast is not fully shown, the radiologist also will refer because there has to be further examination before they can decide what to do. So it's a kind of chain of quality: equipment, radiographers and radiologists. A quality system is, we think it's about guidelines. You need guidelines because you want to measure your quality. Are we doing the right things in the right way? But also you have to have a quality assurance by teaching your staff, testing the equipment and auditing the staff. And by auditing the staff, we don't mean auditing the procedures, but we mean auditing the performance of your staff. And also a quality system has to look forward, so you want to optimize your quality by feedback, monitoring and evaluation, innovation, sometimes from the vendors, sometimes from doctors, and scientific research. It's important to make your program better. Guidelines, of course, they're made by cancer societies, and they are guidelines for equipment, for radiographers and radiologists. And in Europe, we have the guidelines for the breast cancer screening programs, and we now have number 4, and we are working on the 5th edition of the guidelines for breast cancer screening. And our organization is participate in writing the 5th edition of the guidelines. Those guidelines are important for your uniformity. So all the radiographers work in the same way, make an image in the same way, and all the radiologists do their reading in the same way. So that's important, so you can reproduce your reading. So every 2 years the mammograms look the same, and you can, as a radiologist, easily compare the rounds. Our organization in the Netherlands is responsible for the physical, technical quality assurance. And that means that we do type testing of new mammographic systems. And only if we say it's good for screening, then the screening organizations can buy that machine and use it for screening. And if they buy a machine and they install it, then we come over and do an acceptance test. And after that, they are allowed to go screening. And in the screening process we do weekly tests, half-year tests, and because it considers a lot of information, we choose to have KnowledgeNet on our website so people can read about what the test is about. But also you can read which machine is approved. For radiographers, we do the same. Every radiographer who works in the screening program in the Netherlands has had an education in our center. And we do quality audits every 3 years with radiographers, and then we look at the images they made. Is the positioning good? Did they perform well? And here you see pictures of training in Curaçao and in Brazil. And it's important that we also have KnowledgeNet for radiographers, so they can read on the internet how to make a special mammogram or what kind of procedures there are. It's all the same for the radiologist. We have a training center, and you see a lot of radiologists behind a workstation, and this is one of our members of the LSCB, and he is giving advice how to read mammograms. Every radiologist has to have an education in our center before they are allowed to read mammograms in the screening program. We also do the quality audits with all the radiologists in the screening program, and with them we look at all the interval cancers. We look at all the cases they referred, and did they perform well. It's a very tense situation because they have to be open in their work and they get feedback on their work. And also for them we have KnowledgeNet, so they can read a lot of the procedures or the tips or the advices we can give them. I've been asked to tell something about our organization and what we have planned. Each year we have a training, digital breast cancer screening for radiologists, and it's an international training in the first week of June. And it's a very individual training for 10 radiologists from all over the world. It's very popular. Each year we are very successful and fully booked out. So for this year's, the first week of June, there's still some places left for an international training. We also developed a European course of breast cancer screening for radiologists with a diploma. And we were asked by the European Society of Breast Imaging to set up such a course, and they want to have a diploma for European radiologists who are screening in centers in Europe, so that there is a uniform diploma and a degree. And the latest thing we did, we developed a self-test for radiologists and for radiographers. So it's a test with 60 cases where the radiologist has to score in which place there is an abnormality and how they define that abnormality, and then they can see for themselves if they are a good are less good radiologists. We developed also some posters about positioning for radiographers. In the Netherlands, each screening unit has this poster in the exam room, so radiographers can see, okay, how do I have to make this kind of image? It's fairly clearly explained with some drawings, and we are also getting a book about positioning also in English this year. In conclusion, I'm almost ready. A well-organized screening program is a long-term program to guarantee continuity. It's important. It's not for a few years. It's a long-term program. Uniform quality of equipment, radiographers and radiologists must be guaranteed. And screening must be organized within the specific culture of the country. The effect of a screening program must be visible. So you have to have registration, monitoring and evaluation so you can measure the performance of your screening program. We think that quality counts. Thank you very much. Well, I don't know about lung cancer, but for the Netherlands, I think it's important. We've been starting the screening program in 1975, 1980. And we have in the Netherlands a culture when you are invited by the government to come to a screening program, you go. So it's about culture also. So I can't say this is the best way to do it in every country, because it's not. And we have also a time difference, because we're now 25, almost 30 years further. So I think it's very wise to look at your culture and what is important for women or for families to so you can address them. And first you have to reach them, so you have to something like a register. Then you have to persuade them to come to the screening and to come back. So it's very important to communicate with them within your culture. We have experience in Curaçao. Letters are not important in Curaçao. Radio is important, so they listen to the radio. So they try to convince women to come to the screening program because they spend a lot of time on that on the radio. In Brazil, they organize parties for women where they can do their nails and their hair, and they have cola and cake. Yeah, and that's their culture, and they're for a whole day. They wait on the central place in the city, and by the way, they do a mammogram. So it's all about culture, but it's something you have to work on very hard. And when the number of participation is changing in the Netherlands, we get very nervous. So we got to do research why it's growing or why is it increasing.